this ICD-10 information to you today. If you have any problems at any time, please use the chat box function. Additionally, if you have any questions at any point in time, utilize that chat box. Other attendees on this webinar will be able to see anything you enter in the chat box. We're going to go ahead and get started. We'll begin with introducing ourselves and giving you a little bit of information about who we are as a company. RT Welter & Associates is a Colorado-based healthcare consulting company. We do E&M and surgical auditing and coding, managed care contracts, credentialing services. We provide a lot of local and statewide services as well as national services. So that's a little bit about where we come from. Two members of our company are presenting this information to you today, and we're going to introduce ourselves in a bit. We first wanted to give you an idea. We came up with the Coffee Klatch. Coffee Klatch is a casual gathering of people for refreshments and discussion. So we are having coffee. We hope you are partaking as well this afternoon. I'm Whitney Horton. I am a certified coder and a certified cardiology coder through the AAPC, as well as an AHIMA-approved IC10 trainer. I have abstract coding and auditing experience in the areas of cardiology and cardiothoracic surgery, and I have extensive E&M auditing experience across the board in multiple specialties. When I'm not ICD-10, which happens rarely nowadays, I like to eat pasta and drink wine. My colleague Tony is also presenting with me. I'm going to hand the floor over to her to introduce herself.
Hi everyone, my name is Tony Woods, and I'm also with RT Welter & Associates. I am a CPC. I'm currently sitting for my CCS, and I'm also an AHIMA-approved ICD-10-CM and PCS trainer. I have expertise in the specialties of oncology and hematology, orthopedic surgery, as well as neurosurgery and general surgery. I've also got quite a bit of experience with evaluation and management auditing as well. As Whitney said, we do have lives outside of ICD-10, or we at least try to. I don't know how successful that's going to be over the next 8 months. But when I'm not coding in ICD-10, I enjoy playing poker, and I also love to shoot really cool guns. So we're excited to have everybody, and we hope that you get a lot out of this presentation.
All right, we're going to go ahead and dive right into some of our information. Today we're going to be talking about both ICD-10-CM and PCS. Just to give you an idea of where we're going to head throughout the presentation, we're going to start by taking a look at some free online-based resources and references, even outside of the texts that you can resource online. We're going to talk about ICD-10-CM first, review some of the prominent coding and convention changes and additions, talk about some code-specific examples. We're then going to move into ICD-10-PCS, review the guidelines, introduce the root operations, and talk about some root operations specifically. And then we're going to give you some information about some training opportunities that we're offering to help you bring your ICD-10 training full circle. So both texts are available online on the CMS website. There's some really great additional resources, even outside of the index and tabular and tables that they offer. So the full texts are available. The guidelines are actually separated out into separate PDFs, so you don't have to kind of get lost in thousands of pages to just reference those. Your index to external causes and your neoplasm table are available in separate PDFs, so you can reference those individually. ICD-10-PCS is available online in its entirety, index and tables. And there are some really great reference resources online that we're going to take a look at so you're aware that they exist. I'm going to share my screen with you. If you have any problems seeing the website I'm about to bring up, which will be the CMS website, use the chat box function to let us know, please. So this is the CMS website, cms.gov/ICD-10. We'll take you to this main screen. If you look over on the left, we have the 2014 and 2013 versions of both CM and PCS. There's GEMS information and also the full text. Take a look at CM first. You've got the tabular list, the index, GEMS map, present on admission guidelines. The references available for CM are also found in your 14 paper copy draft if you have that, with the exception of the related link, which is an addendum. One second, I understand you can't see the screen. Just one moment. Sorry, it was brought to our attention you couldn't see the screen. It eliminates our chat box visibility when we brought this up, so I'm going to start fresh. This is the CMS website. I'm sure many of you are familiar with it. cms.gov/ICD-10 will take you to this main site. Over on the far left, we have all of the options for the 2014 and 2013 versions of the draft. Right now, I'm taking a look at the 2014 ICD-10-CM. Your tabular, your tables, your non-admission guidelines, everything's available to you here. GEMS maps, so a lot of good tools here. (2014) ICD-10 PCS and GEMS. The full text is available, as is with ICD-10-CM. There are also many additional references here. There's a PDF regarding the development. Probably one of the most useful tools on this is the reference manual. There's a lot of really great information in the reference manual that provides further detail about root operations, how to apply those root operations. I highly recommend, if you're coding using ICD-10 PCS, printing that reference manual and having it available to you while you're practicing coding. I just wanted to take a quick look at that. We're going to get back to the presentation. Okay. So we're going to start off with ICD-10-CM, talk a little bit about the conventions, the chapter guidelines, and then we'll take a look at how those conventions and chapter guidelines apply to some code-specific examples. So our code structure in ICD-10-CM, all codes are 3 to 7 characters. The first character is always alpha, second character is always numeric, and the remaining characters may be either. There are valid 3-character codes, and there are many codes that require 7 characters. Decimal place after the 3rd character if more than 3 characters exist. 7th character extension required for many chapters and many codes in a select number of chapters in ICD-10. We're going to be talking about that a lot today because it really is the root of a lot of the concept additions. Important convention addition in ICD-10-CM, we now have 2 types of excludes notes. These will be indicated to you in your tabular list. Excludes 1 notes indicate when the code you're referencing is by definition included in that code, and another condition should not be coded in conjunction. Excludes 2 notes indicate when the code you're referencing by definition excludes that term, and if both conditions exist, they should both be coded. So really important to make that distinction between these types of excludes notes. It will always be the difference of reporting 1 or 2 or more diagnoses when you're referencing a particular condition. includes notes and inclusion terms. This is a convention that maintains its definition in ICD-10 from ICD-9. Includes notes appear immediately under your 3-character subcategory to give you kind of a description, more detail about what that subcategory means. And then your inclusion terms are lists of terms under full codes or additional subcategories that give you an idea of types of conditions that may be included in that code that aren't themselves the actual code description, like it does in ICD-9. We have 21 chapters in ICD-10, up from 17 in ICD-9. For the most part, what we think of as V&E codes now, those types of descriptions have been reclassified into the main chapters. Supplementary information like that still exists. It's no longer considered optional to report, and we'll talk a little bit about those types of circumstances later. Diseases of the eyes and ears now have their own chapters in ICD-10, and certain diseases have been reclassified into seemingly more appropriate chapters. Gout is now located in the musculoskeletal chapter. There are expanded code sets for alcohol and substance abuse. We're able to reflect the degree to which those substances are being abused, whether it's in remission. The guidelines have been clarified on how we define the way we're describing the abuse and use of those substances. Extensive ulcers have been greatly expanded in the integumentary chapter to be able to describe the level to which the skin is broken down. Laterality is a big concept that's been added and accounts for the majority of code expansion in ICD-10. In obstetric codes, we've changed the way we define those. They're now defined by trimester, rather than the episode of care they were defined as in ICD-9. The hypertension table has been removed. We'll talk about the code we use for hypertension a little bit later. So ICD-10 comes with a large number of combination codes, which by their definition include the disease process with any manifestations, any symptoms it might be present with, etiologies, lots of combination codes. We have expanded injury codes in regards to laterality, anatomic site, encounter of care, which we'll talk about. We have a new concept of underdosing in our table of drugs and chemicals. And we're able to reflect intent within a poisoning code description. Some code-specific examples of things that we can capture with ICD-10 that we are not able to capture with ICD-9. Everything in blue on this page were concepts that we couldn't capture in ICD-9, even if they were documented well and were present. Our first example has to do with diabetic retinopathy. You'll see in this code description we capture the type, the severity, and the manifestation of macular edema, all within one code description. The combination codes are very high level specificity in ICD-10. The second example is an injury code. We have a dog bite with fingernail avulsion, and in our ICD-10 code, we're able to reflect that there was damage to the nail as well as the open wound. When I look at this, I think medical necessity all the way around. If you're in an office setting and you have an open wound like this and the fingernail is involved, that could be the difference between having a repair code and a fingernail removal code. So medical necessity is going to be, it's going to be easier for us to support with our diagnosis code selections with ICD-10. Underlying causes are given more priority in ICD-10. The diabetes code series is probably the most prominent example of that. An example here with diabetes, type 2 diabetes with nephropathy. The example below are intraoperative and postoperative hemorrhages have now been reclassified into the chapter of the organ system which they're affecting or which they're a complication of. And they've also been separated. Intraoperative and postoperative hemorrhages each have their own code definitions. In ICD, we had one code for hemorrhage complicating a procedure. So now we have two codes, one for each body area or organ system. This could be a complication of. This is just a nice visual. We just took a look at a couple of codes and we saw the high level specificity. So we really are able to convey a level of specificity that we don't have the option to convey in ICD-9, even if our documentation contains it. So in ICD-9, our injuries, which would currently be our 8 and 900 codes, are classified by body site and then by type from least severe to most severe. So if you code from your books, this is going to be advantageous to you in that it will make it a little easier and perhaps quicker to find your code when you're looking in the tabular section. Character X is used as a 4th, 5th, or 6th-digit placeholder in many codes, codes that require a 7th character to convey certain information, but their core definition only has 3, 4, or 5 characters. You'll be using character X to fill in those places. Character X is used only as a placeholder. That brings us to the 7th character code extensions, which we'll be talking a little bit about today. We convey information about injuries, external causes. It's used in the obstetrics chapter a lot, and you'll see a lot of character X's to hold those places with these chapters as well. Just a note about some of the types of things the 7th character can reflect. This is specific to injuries and the encounter of care, whether it's the first time the patient's seen for that injury, it's, they're receiving routine care for that injury, or they've developed a sequela from that injury. Just a couple examples of what that 7th character can reflect. The meanings vary dependent upon chapter and code series. So in many cases, the use of the 7th character takes the place of our aftercare codes, what were V codes in ICD-9, or that now exist in much lesser volume in ICD-10 as Z codes. And in Chapter 15, we reflect things like trimester or certain complications of multiple gestations with the 7th character. Talk about some of the chapter-specific guidelines. Probably the most notable addition is for Chapter 19, and it involves our encounter characters. These are our 7th characters that we just talked about. So if you'll notice these 3 characters that are up on the screen now, A, D, and S, those are the sole encounter characters available to us outside of fractures. So learn to love A, D, and S. And we'll define what initial, subsequent, and sequela mean from a coding perspective as ICD-10-CM defines it. And then we'll talk about fractures and how those differ. So an initial encounter is defined in the Chapter 19 guidelines in ICD-10 as to be used when the patient is receiving active treatment. ICD-10 gives examples of active treatment to include initial encounter, surgical treatment, emergency department encounter, and evaluation and treatment by a new physician. So an initial encounter character would be used for the first time the patient presents for that injury in the ED, when they're referred to an orthopedist for treatment, during the surgical encounter, and then we move away from the initial encounter character. The way that this is described on the screen now is the same verbiage ICD-10 describes it in the chapter guidelines. So you'll notice that evaluation and treatment by a new physician, it doesn't define what it means by treatment, and it also doesn't say new physician of a different group. So some misinterpretations are possible with this, but this is exactly the way ICD-10 describes it for us. Subsequent encounter is our 7th character, D. So subsequent encounter is defined as having been after the patient has received active treatment and is receiving routine or follow-up care during the healing or recovery phase. You'll notice that that description, the verbiage sounds very similar to the V codes we have in ICD-9 for fracture aftercare. So cast changes or removals, removals of internal fixation devices, things outside of fractures, suture removal, things like that are going to fall into our subsequent encounters. So our aftercare Z codes, which very few exist, they should not be used. They should rarely, if ever, be used. For the most part, we're going to have the original injury code with the 7th character to reflect that it's aftercare. Our encounter character S is for sequela. The sequela encounter character should be used in the 7th place when it's documented that the patient presents with a new condition that is documented to have arisen as a direct result of the original injury. So we need to have that connection made in the documentation to be able to apply this encounter character. And the way that we series these is the first code is going to be the code for the new condition, whether it's a symptom, a disease process, whatever it might be, followed by the code for the original injury with the 7th character of S. So a couple of things to note about this. We have to encourage the specificity in the documentation connecting these two diseases or the symptom with the former injury. We also need the level of specificity regarding the original injury to assign the most appropriate code for that original injury, whether it happened 6 months ago, a year ago, whatever it might be, so we can assign the highest level specificity injury code with the 7th character of S. A couple of examples here. Patient with numbness in the finger a year after a fracture. We're going to sequence our numbness in the finger first, followed by that original fracture code with 7th character S. And those sequencing guidelines are laid out in our Chapter 19 guidelines. So A, D, and S, we just defined those. Those maintain their definitions. You'll see the verbiage change a bit when they're used with fracture code series, but they do maintain their initial, subsequent, and sequela definitions. To give you an idea of how fractures vary, for any code that involves a fracture, these are the total number of 7th characters that are available to us. Not all of them are available for every fracture code series. You'll know which ones are available to you for a particular condition you're trying to code by the red boxes in your tabular list. Some fractures are by definition closed fractures, and the open fracture 7th characters will not be available to you to use with those to create a valid code. But this is every character that's available to us with fractures. The open fracture types are based upon the Gustilo open fracture classification system. So for those of you who work in an orthopedic setting where perhaps your orthopedist treats in a surgical setting open fractures, that level of detail about the extent of the fracture now needs to be known even when that patient follows up in the office. And remember, each of our notes has to stand alone. So that level of detail needs to be present for us to select these codes throughout the entire life of the injury, even for follow-up. Burns and corrosions are also in Chapter 19, our injury chapter. And we're outside of fractures now, so the only encounter characters that apply are A, D, and S, and they maintain their definitions. Burns and corrosions have been separated out based upon the source. So our burns are defined as thermal from a heat source, and corrosions are defined as due to chemicals. You can index burn or corrosion. If you index burn due to chemical, it will tell you to see corrosion. So classifications here. The source, it must be documented for us to appropriately select a code. Our poisonings, underdosings, and adverse effects, also in Chapter 19. The drug and chemical table has a new column for underdosing, has a column for adverse effects, and has multiple columns for poisoning based upon intent. So our poisoning codes now include within their definitions whether it was accidental, assault, intentional, or undetermined. It should be noted undetermined is for use only when it's documented that the intent, whether it was accidental or intentional, cannot be determined. Undetermined should not be used when nothing is documented regarding the intent. It should be coded to accidental if no information is documented regarding the intent. So accidental will probably be used more frequently than undetermined. Seventh encounter characters A, D, and S apply. Those are the only seventh characters that apply, and they maintain their definitions. The underdosing column will only contain code selections for those substances which apply to it. We'll go ahead and define those. So underdosing is taking less of a medication than is prescribed or instructed to take by a physician or a provider. So an underdosing of rat poisoning, for example, that code selection doesn't exist because that's not a substance that would be advised to take by a provider. Poisoning and adverse effect, we have those concepts in ICD-9. Their definitions are maintained. They're elaborated upon a bit in the chapter guidelines. Adverse effects gives us some key words to look for. So if we see these words documented and it's in regards to a correct substance properly administered, we know we can use our adverse effects code. So for underdosing, which is our new concept, we're instructed to use additional codes for the nature of the underdosing. Whatever symptom was created or occurred as a result of the patient not taking the right amount of medication. We also have codes to describe the circumstances behind that underdosing. So these would be your non-compliance patients. Now, instead of just our non-compliance code, we can say the patient was underdosing and what type of medication they weren't taking enough of within our underdosing code. We can say what happened as a result of that, and we're also able to say they did it because they did it for financial reasons. So we're able to convey a lot more information about that particular setting. External cause codes are codes that would maybe be considered equivalent to our E codes now. If you read your Chapter 19 guidelines, you'll notice that it refers to Chapter 20 very frequently. So it's hard to talk about Chapter 19 without also talking about Chapter 20. So Chapter 20 includes our external cause codes. So an initial injury claim, whether it be an ankle sprain, a finger laceration, a fracture of the wrist, could be expected to have, at a minimum, 5 codes. We're looking at our injury code to reflect the actual injury, which will be an S or a T code. The external cause of morbidity, the accident, it was a car accident. The patient fell off a horse, was struck by an object. They sound very similar to our E codes, but they've been greatly expanded. Activity, place of occurrence, and we have a new category for external cause status. External cause status, there are only 5 codes in the category, and they reflect whether the patient was working, partaking in a volunteer activity, on active military duty, or other specified external cause status. It should be noted that for activity, place of occurrence, and external cause status, unspecified options are available. So there is an unspecified activity code. Our chapter guidelines instruct us never to report those codes. So there's 3 codes in ICD-10 you will never have to worry about knowing. So we'll bring it all together now. We've got our stories from the emergency department and a very fierce-looking raccoon. So we have our injury code, which is our S code, open bite to the index finger, no damage to the nail. We saw that we were able to reflect that information earlier. The patient was bitten by a raccoon while milking an animal in the dining room of a mobile home, and he was volunteering. So you can see the story we're able to tell with these codes. As a note, our chapter guidelines also tell us to report an activity in conjunction with your external cause code only if it provides additional information. So for your car accident codes, driver of a motor vehicle injured in a motor vehicle accident, You do not have to select an activity code that says driving. And your chapter guideline kind of guidelines give you some direction on that. If you feel like you're being redundant and you've already captured it in your external cause code, no need to also report an activity code. Another note, our external cause codes, which in this case is our W55 code, the accident itself, our chapter guidelines instruct us to report that during every encounter which the injury is evaluated. For activity, place of occurrence, and external cause status should only be reported on the initial claim. So we're going to need the circumstances of that injury in regards to the accident itself each time, so we can report that information, and each note should stand alone to support that. So that covers the biggest areas of change, chapters 19, and we talked about chapter 20 because they go hand in hand. Greatest area of code volume expansion and biggest area of concept additions. We're kind of going to go back to the beginning of the book now, talk about some code-specific examples starting from chapter 1 and just moving forward. So in chapter 1, we have our sepsis guidelines. Many of them are similar to those of ICD-9, but ICD-10 does a better job of directing us to which specific code categories to utilize in conjunction with each other. Minimum of 2 codes. We want to describe that underlying infection. Documentation specificity is going to be really important here. I know sometimes we don't always get that even with our ICD-9 code selections. So really take a look at those sepsis guidelines if it's a condition that you code frequently. Your tabular list does a good job of instructing you which code series to use in conjunction as well. Chapter 2, our neoplasms. We have a change in the guideline for anemia associated with a malignancy. If the encounter is for management of the anemia, we're still going to code the malignant neoplasm first, followed by the code for anemia and neoplastic disease. So it's going to be really important that we have the level of specificity we need to assign the appropriate malignancy code, even if that patient is coming in for treatment of their anemia. Now we have options for laterality, more anatomic site selections. So if all we have is anemia associated with breast cancer, our primary code is going to have to go out the door with a much lower specificity code, unless we really encourage our providers to convey all of that information in their documentation and during every encounter. So the concept of laterality has been added to this chapter for body sites or organs to which it applies. This is an example of malignant neoplasm of the breast. We're probably used to seeing 174.9 on almost every claim that goes out the door. And if you'll notice, the very last code that has that red note on it, that's the GEMS bidirectional choice for 174.9. That's why it's a danger to us as coders to use GEMS for forward mapping purposes and reporting purposes. The concept of laterality couldn't backwards map to anything because the concepts didn't exist in ICD-9. So make sure you're aware of which codes laterality exists for. Chapter 4 are endocrine, nutritional, and metabolic diseases. Diabetes codes have been greatly expanded. They're the best examples of codes that include manifestations, underlying causes. And the concept of unspecified type of diabetes, our favorite code 250.00, that concept no longer exists. Our chapter guidelines give us a default option. It tells us that if the type of diabetes is not specified, we should use type 2. But if your providers are accustomed to not documenting the type, every single patient they see for diabetes is going to be reflected as a type 2. So make sure they're aware of what information they'll be communicating to the insurance company if their documentation is lacking. This is just an example of a diabetes code range example that talks about some manifestations. So in this case, we've got diabetic retinopathy. We're able to reflect the type of retinopathy and whether or not macular edema is present. Code descriptions is unique and different. And the more specificity that's in your documentation, the more confident you can feel selecting a higher specificity code. In most of the diabetes code ranges, additional codes to describe the manifestations are not necessary. There are very few exceptions, one of which being renal failure. You're always going to have to assign a code from the renal chapter to describe the stage of the kidney disease, and also for heart failure. But for the most part, these combination codes don't require codes from additional chapters to be reported in conjunction with these. Our guidelines also tell us to report as many diabetes codes as necessary to reflect the full spectrum of the patient's complications. 9 are diseases of the circulatory system. We talked about how the hypertension table has been removed. We have one code for hypertension now, so that's a small victory for us as coders. And the code is I-10, which is easy to remember. So if you walk away with anything, walk away with having one ICD-10 code memorized. So ICD-10-CM no longer makes the distinction between benign or malignant or unspecified hypertension. There's one code, and I've listed the inclusion notes as they appear in the tabular list. So I-10 is your code for hypertension. CAD and angina, combination codes have been created to reflect when these conditions are present together. Our chapter guidelines tell us that this relationship should and ought to be implied unless very explicitly stated otherwise in the documentation. So what we previously had to use 2 codes for, and in an inpatient setting decide which should be the primary reported, we now have one combination code for. Go back. Another note about CAD, our unspecified type of CAD, 414.00, one of our other favorite codes, unspecified of vessel no longer exists in ICD-10. It needs to be documented whether a native, a graft, a vessel of a transplanted heart, that type of information has to be documented to appropriately select a CAD code. Chapter 13, diseases of the musculoskeletal system. So we see our encounter characters come back in this chapter because our pathological fractures are no longer the same in some cases, the traumatic like they were in ICD-9. Now pathological fractures are located in the musculoskeletal chapter, and their 7th characters apply as they relate to that type of fracture. So we're still able to reflect, and we have to reflect, whether it's an initial, subsequent, or sequela encounter. We're able to reflect the type of healing, malunion or non-union are included in K and P, or between G, K, and P as our 7th character. There's also an option for with delayed healing. Again, you'll know which of these are available to you for any particular code series you're using by the boxes available to you in your tabular list. We also have the concept of laterality in the musculoskeletal chapter, has to account for a lot of the code volume expansion. For those body sites or areas for which laterality doesn't apply, we have increased anatomic site selections. This is an example of disc degeneration. We had a code in ICD-9 that's 722.6, which was for degeneration of invertebral disc specified site. That option no longer exists. If you don't know the level at which that degeneration is occurring, you cannot code the disease. You would have to query the physician. So while unspecified codes do exist in ICD-10, they've been limited. And there are cases where something you could code in ICD-9, you can't even select a low-level specificity code for an ICD-10. And this is a really good example of that. Chapter 15 is our pregnancy chapter, codes to be used on the maternal record only. That episode of care classification that we have in ICD-9, antepartum without mention of complication, postpartum without mention of complication, delivered, for the most part that has been removed as a class. There are still codes that detail whether the condition happened during delivery, but really it means something different in ICD-10. In ICD-10, all of our obstetric codes for which trimester applies are now classified by trimester. And we have guidelines as to how we can kind of pull that information out of the documentation. The provider can document weeks. We can put that into a trimester as ICD-10-CM has defined it, and then apply our trimester character to our obstetrics code. There are code selections for most of these, for any of the categories that require a trimester. For unspecified trimester, it should be used rarely. And probably the two best examples of when it should be used in an emergency situation where really the patient's being transferred out immediately. It's not meaningful to have documented the weeks pregnant, or a situation where the provider doesn't know, it's a newly pregnant patient. But even then, we might have enough information to know that it's still. Chapter 21. The equivalent of our V codes. We're able to reflect certain socioeconomic statuses that we don't have the capability to report in ICD-9. These are some examples above. So poverty, low income. When I see some of these, I think about supporting time-based E&M coding for a patient that's receiving an extensive amount of counseling. Our low income or poverty could support our non-compliance patients. Blood alcohol level to be used in conjunction with those alcohol abuse codes. So a lot of this is being used for data collection, and they're utilizing you and your providers to do that. But some of this can support us from a medical necessity perspective. Routine examinations are V70.0. Not a huge change here, but in ICD-10 we are able to reflect whether or not abnormal findings were encountered. Same with our routine child check codes. Here's another little victory for us with ICD-10. Encounter for immunization, we have one code now. There's no more need to worry about linking the right V code with the right vaccine and immunization administration code. So Z23 takes the place of over 3 dozen ICD-9 codes. So now you can walk away having 2 ICD-10 codes memorized. Z23 is your encounter for immunization, regardless of type of immunization. So what does this mean to you and your providers? How can you help, how can you assist in your provider's documentation education needs, which can start now and already started. And documentation education doesn't necessarily have to be specific to ICD-10. It can be in your brain, but when you educate them, making the note that they said the patient had diabetic retinopathy, but they didn't say if it was severe or mild. And that all comes back to you being able to select a higher level specificity code. So there's a couple things I think you can encourage your providers to do and not to do. Some things to caution your providers against, allowing their EMR code selection to drive their assessment. Those notes that we see where the only information pulled into the assessment are code descriptions. That's going to be hard for us to pull out anything. If additional specificity exists, it's going to be difficult to capture if we don't have any additional information in our assessment. Another thing that ties into this is selecting the first in a drop-down list. We know that search functions in EMRs aren't always our best friends, but with ICD-10, we even more so run the danger of having such a long list to scroll through with one key word that selecting the first is almost always going to give you not the highest level specificity code, perhaps not a code that actually reflects what you've documented in the rest of your note. So we really want to caution them against that, particularly in the case that for your database conversion you've used GEMS, which is what it was intended for. You could wind up with a forward map that has a list of 80 codes in it that now your provider is going to have to scroll through to try and find the appropriate code to reflect the encounter that they're coding, and they might not want to spend a lot of time finding the appropriate code selection. So what can you do to help with the documentation education needs? So encourage your providers to realize that the documentation in its entirety should support their code selection. So we can take laterality from the HPI, we can take laterality from the physical exam. And as coders, we're going to have to become more accustomed to looking at more context of the note than perhaps we're used to doing now. And this, all of these examples can go back to ensuring that your vendors don't select the unspecified option in their EMR dropdown, because then you'll wind up with a situation where they have unspecified pain in the foot in their assessment. Their physical exam and HPI, we know it was the right foot. So a thorough HPI and examination of affected area are going to help us with code selections, particularly in the musculoskeletal and injury chapters. So this is an example of the ulcer codes, the level of detail we have and the extent of the breakdown of the skin. We can pull that information from a well-documented physical exam and apply the highest level specificity code we can. So documentation improvement throughout the entire note is going to help support the code, high specificity code selection. So open up the lines of communication. Encourage your providers to communicate you, and encourage them to encourage you to communicate with them. If you find notes that they selected a very non-specific code in their assessment as a function of the EMR, but their note as a whole supports a higher level specificity code, bring that to their attention and let them know why. And on the other hand, if you are seeing a lot of unspecified codes going out the door and their documentation really isn't supporting anything more than that, help them understand what they might not be capturing, because in their brain they know what they were thinking when they selected that code in the EMR. It's just not reflected in their documentation. Help them understand that it needs to be reflected in their documentation to support that code in the event of an audit. So like I said, our unspecified code selections are dwindling. I would anticipate they will continue to do so. So the more we can encourage our providers and ourselves to really be wary of those code selections, the better off we're going to be and the easier it's going to be for us in the future. So another thing I just wanted to note one last time, it's important that the documentation in its entirety supports the code selection outside of the code description that's been pulled into the assessment portion of the note. The example I gave the patient for which that particular ICD-10 code was pulled in for diabetes with a foot ulcer, for which we have no notation of foot ulcer anywhere else in the note. Just because that diagnosis description is pulled in does not mean it's appropriately supported, which is another danger we run sometimes with EMR code selections. So just really help your providers understand the importance of this, and help them understand the best ways they can search these terms in their EMR, sit with them and see what way works best for everyone. I'm going to turn the floor over to Tony, and she's going to talk to you about ICD-10 PCS.
All right, perfect. So hopefully there are some hospital coders on the line, and if there aren't, that's okay. I want to preface all of this with ICD-10 PCS really provides a window of opportunity for coders and coding professionals. This system has changed so much from ICD-9 that, you know, there's not a lot of literature out there about it. Aside from what Whitney showed you with the references, there's not a lot of literature. So we're kind of all on the same playing field. Once ICD-10 goes into effect on October 1st, as I'm sure you probably picked up with the ICD-10-CM going through all of that with Whitney, coders that have been doing this for a while, seasoned coders, they're going to get this just fine. The battle is going to be productivity. It's going to be, you don't have all the codes memorized in your head, so you can't, you know, finish as much as you could have done in ICD-9. But PCS is really a whole new ball game. So ICD-10 PCS is used only in the inpatient setting. They took a huge hit. They went from 3,000 codes in ICD-9 Volume 3 to 72,000 codes in ICD-10 PCS. So ICD-10 PCS completely replaces ICD-9 Volume 3. It's a multi-axial 7-character code structure. We'll talk about how those characters are built specifically throughout the rest of this presentation. ICD-10 PCS is maintained and organized by CMS. So they are actually a little bit different than CM. ICD-10-CM is still maintained by WHO, the World Health Organization. So PCS is regulated by CMS, and it explains a lot of the confusion that's involved with ICD-10 PCS. All right, so the text structure is the same. There's a separate book for ICD-10 PCS. As Whitney showed you, there's an online version you can look at if you didn't want to purchase the book. It's similar to the ICD-10-CM setup. The intro is in the beginning, the conventions with the guidelines, and then you have the index and the tables, which are kind of like the tabular, and then you have all of the appendices. So before we get into the root operation guidelines and all of that, there are a series of convention guidelines. This is kind of explaining how that's formatted. So you've got code composition, you've got the alphabetic index, PCS tables, etc. We also have our PCS guidelines. We have 4 sections. So we have our conventions, which kind of talk about, you know, how to use the tables and how to navigate the book. Then we have guidelines specific to the medical and surgical section. This is where the majority of all procedures coded in PCS are located. We'll talk about this section more in a minute. There are also separate guidelines for the obstetric section. Procedures done in this section you wouldn't typically probably consider to be done in the obstetric section. These are procedures done on products of conception. So not deliveries, but actual products of conception. So an example is something like an amniocentesis. That is a procedure that would be coded in this section. And then there's a section of guidelines for selection of principal procedure. So this deals with sequencing of principal procedure and how that process works in the inpatient setting. This guideline is pretty significant. Providers are really, really going to like this. Basically, there's a guideline in PCS that states it's the coder's responsibility to determine what the documentation in the medical record equates to in a PCS definition. And we'll talk about how this can get very confusing more in a little bit. But basically, this puts the responsibility back on the coder to determine from the documentation how that fits into PCS definitions. And as I said in the very beginning, PCS was created by CMS. So all of this information is derived from them, and they don't define things as normal or as you would like them to be defined. And we'll talk about that more extensively in a minute. So basically, this guideline equates to the provider doesn't have to use the verbiage that PCS uses. They can say, you know, that they did a partial resection, but you as the coder have to take the initiative to equate that to how it's going to fit into PCS. So you use the book pretty similarly to CM. The index, if you index the root operation, the root procedure, the procedure type, or a common procedure name like bypass or resection, that's going to lead you to a table. And so you work out of the tables kind of like the tabular, and the index is the same, and you code straight from the tables. There can be multiple pages with the tables expanding, so you have to be really careful when you actually look in the book to make sure that you're on the right table. And you can't code from the index. All right, so all codes in PCS have 7 characters. Each character has a unique value, and the letters O and I are not used in PCS. That's kind of nice because we don't get confused with ones and zeros, which are used. Meanings change by sections, and the first character is the section character. And this is basically the broad procedure category where your code is going to be selected. So that's the first thing that's built when you're coming up with a PCS code. Here are all of the PCS sections. There are 3. The medical and surgical section, which I talked about in the convention section, it has its own set of guidelines. I'm sorry, not the convention section, the guideline section. That's the largest section of PCS. The other 2 sections are not as widely used, but they're still very important. The medical and surgical related sections, which include the following subsections: obstetrics, extracorporeal, assistance and performance. Those are some examples. And then the ancillary sections, which include imaging, nuke med, mental health, those types of services. So the medical and surgical section, the largest section in PCS, as I said, there are so many things found in this section, from hernia repairs, deliveries, endoscopies, to cardiac mapping. The second character in PCS is the body system character. And this is generally the physiological system or anatomical region involved in the procedure. Body systems are a little bit, they're defined a little bit differently than how you might think. I personally think of body systems like organ systems. When I'm auditing, you know, E&Ms and you're counting the physical exam, that's really where I get that information. So that's how I think about body system. But PCS thinks about it a little bit differently. Some examples of body systems classified in PCS: the central nervous system is a body system. The muscles are a body system. The mouth and throat is a body system. And there's actually no circulatory system. It breaks it out more granularly. The third character in a PCS code is the root operation. Every character in a PCS code is equally important, but this is really the most important and the main piece of the procedure. It's the objective of the procedure. Why was it done? What was done? And there are 31 root operations, and we're going to talk about those more extensively. So here are the 31 root operations in the medical surgical section. As you can see, they're very broadly categorized, or very, very broad. So inspection, detachment. We're going to talk about some of these more in depth to give you an idea of how they're really defined in PCS. So the root operations, the 31, has been grouped into 9 categories based on what the operation does, what's the objective of the procedure, and the procedure site. So these 9 groups are put together based on similarities. Some examples: root operations involving cutting or separation only, root operations that always involve a device. So you'll see these are very broad categories. So here's one of the probably the most used root operations or common root operations, excision. And this is the root operation in the category that deals with root operations that take out some or all of a body part. Some examples are partial nephrectomies, breast lumpectomies, biopsies. Biopsies are classified in the root operation excision. One way to identify that it's a biopsy is with the qualifier character, which we'll talk about in a minute. So we talked about excision. Resection is in the same category as excision. So dealing with the root operation taking out some or all of a body part. By definition, resection is cutting out or off without replacement all of a body part. So the difference between the two is a portion versus all. And this can be a little confusing because body part has its own definition based on PCS. So you have to understand what's defined as a body part in order to determine whether it's going to actually be a resection or an excision. So some examples of excision are a total mastectomy or a total nephrectomy. So as you can see, that could be really confusing. We'll talk about body parts more extensively in a minute, but the difference mainly between excision and resection is the body part, how the body part is defined. PCS defines some body parts more granularly. For example, the lungs. They actually break out the lobes of the lungs. So if you're removing a whole lobe, you're technically resecting it because it's a whole body part, instead of just partially removing the lung. So very important to understand the difference there. Another root operation, it's in actually a different category than the previous two we talked about. It deals with the root operations that involve cutting or separation only. So by definition, this is cutting into a body part without draining from the body part in order to transect or separate. That's the objective of this procedure. Some examples are osteotomy, neurotomy. Release, very similar and in the same category of root operations as division, defined as freeing a body part by cutting or by use of force. The best example is carpal tunnel release. You're taking the nerves and you're freeing them up from that tissue that's causing pain. Release and division can be confusing because they seem very similar. So PCS has actually created a chapter guideline to overrule, I think, the definition of these root operations. So instead of trying to make it fit into which definition or which root operation, it really comes down to the sole objective of the procedure. So if the sole objective of the procedure is to free the body part without actually cutting it, the root operation is release. Whereas if the sole objective is separating or transecting a body part, it's division. So an example of release is freeing that nerve in carpal tunnel from the surrounding tissue to relieve pain, whereas division is severing that nerve to relieve pain. Detachment is in the root operation that deals with dealing with only upper and lower extremities. So we're cutting off all or part of the upper or lower extremities. If you're not with the upper or lower extremities, you're not in the right root operation. Some examples: below the knee amputations, amputation above the elbow. And the best way to look at detachment is to basically associate it with amputation. Detachment equals amputation. And detachment procedure codes are found only in body systems. So again, you have to be dealing with the upper or lower extremities. Detachment qualifiers, we'll talk about the qualifier character in a minute. It is the seventh character, And this will provide a little bit more information about the actual detachment procedure. Extraction is a different root operation. It basically pulling or stripping out or all of a portion of a body part by use of force. So the key here is you're using force. The best example is a DNC. You're taking, and we'll talk about DNC in a minute, but basically extraction is you're using pulling or stripping in order to remove or take out that body part. So DNC, dilation, where you're widening the cervix to allow the instruments into the uterus, and then the curettage is scraping of the walls of that uterus. So the scraping, the widening, that all falls into extraction. And when you're coding a DNC, there is a guideline that states that dilation cannot be separated. It's actually got to be reported together, because in order to get to the point where you're actually scraping the cervix or the uterus, you have to dilate. Important thing to note with extraction, if it's done for non-medical purposes, so cosmetic reasons, liposuction, that changes the definition of the root operation and now becomes alteration. So important thing to note, we talked about this with the coding guideline. Basically, it's very important that you familiarize yourself if you're coding in PCS with the PCS definitions. So the root operations, body parts, you've really got to know that stuff like the back of your hand in order to select the right code. So if a provider documents in his procedure note that he did a removal, although he said he did a removal, he really performed an extraction based on the definition of extraction and the procedural documentation. You as a coder have to be able to draw those conclusions. Extirpation, this is my favorite root operation, I like to say it. It's taking or cutting out solid matter from a body part. So the main thing to note with this particular root operation is that it's not a focus on the body part. It's a focus on the procedure. Some examples are thrombectomies. The best example is excision of foreign body. Extirpation, again, you're dealing with the actual procedure. You're not focusing on the body part itself. Everybody that has a child has probably seen this, or if you know a child, all kids put things up their nose. Extirpation is probably the best way that I remember it. A kid getting, something up their nose and it having to be removed by a physician. Another example, removing a tampon. So we're going to look at 4 root operations that are in the same group. So we talked about the 9 different groups, the 31 root operations. We're going to actually look at a whole group, see why they're grouped together, and kind of paint the picture for how this can be a little confusing. So transplantation, basically, this is a pretty narrow procedure range. If you index transplantation, it comes up with these options. So the esophagus, the intestine, the lungs, you can only do transplants on certain organ systems or organs. And this is the root operation. Again, all of these are going to be in the same category that deals with putting in, put in or put back or move some or all of a body part. So that's transplantation. Reattachment, so procedures that involve putting back a body part that has been cut off or avulsed. The best way to describe reattachment is you lost your finger in an accident or something, you cut it off by accident, and then you decide that you want to keep your finger, so you put it in an ice bag and you take it to the hospital, and then a surgeon puts it back on. That's basically reattachment. You're taking something that was cut off or avulsed and you're putting it back. Transfer, So you're taking a body part and you're transferring it to another location, but you're not disrupting any vascular or nervous supply. So you're not fully removing the body part. An example of this would be an adjacent skin tissue flap transfer. You're moving that skin. You're not actually removing it completely. Reposition, also in the same group of root operations as transplantation, reattachment, and transfer. I actually had this surgery when I was a kid. I broke my wrist, and that's the best way to remember reposition. You're repositioning something. So you're taking your wrist and you're resetting it back to the correct location. Reduction of a displaced fracture. Not to be confused with immobilization. So when you're repositioning it, if you're also applying a cast in order to immobilize it, you wouldn't break out immobilization separately. That's included in the reposition. So out of those 4 root operations, you can see how those can be very similar and perhaps cause some confusion. So here are the comparisons. A transplantation is a new body part from outside the body. That's the best way to think of it. If it didn't come from someone other than the patient, but outside the body, it probably will not fall into transplantation. Reattachment, you're taking the original body part, the original function, and you're replacing it at its original location. Transfer, you're taking the original body part and you're moving it, you're relocating it, an adjacent tissue transfer. Reposition is taking the original body part and moving it and altering it, changing the location. So all of those root operations are in the same group based on similarity, and you can see how they might be quite confusing. All right, so back to building your actual PCS code. Those were just the root operations and some examples. The 4th character in a PCS code is the body part character. So this, not to be confused with body system and character 2, usually defines the anatomical site for the procedure. There's 34 possible values for body system. It may specify laterality. For example, the left foot or the right cephalic vein. Those are examples of body parts. So as I said, you don't want to get the 2 confused. When you look at body system, think more general. And then when you look at body part, think more granularly. So the body part in character 4 is going to indicate the specific part of the body system in character 2 for which the procedure was performed. So again, thinking more granularly. So as coders, we've heard a lot of buzz, about how we need to beef up on our anatomy, and that is very true. It's important that we understand anatomy now better than ever, and especially so in the PCS coding setting. Very important to understand anatomy. So they don't just want you to know, the difference between the peripheral and the nervous system. They want you to be able to identify particular organs in the nervous systems individually. So the central nervous system, the trigeminal nerve, the brain, the peripheral nervous system, the ulnar nerve, the tibial nerve, the sacral nerve, or the sacral plexus. These are all things that we didn't really have to bother ourselves with knowing, but we now should know in order to select the most appropriate code. The 5th character is the PCS character for approach. So the technique used to reach the site of the procedure. There are 7 different approaches. I can tell you from personal experience, I almost always get this one wrong because it just seems like the verbiage is never the same. So the 7 different approaches are grouped into 3 categories. External, was it accessed through the skin or mucous membranes or through an orifice? When you're assigning the approach value, you want to make sure that you remember the approach value defines the technique used to reach the procedure site. So not the instrumentation that was used, the approach. So here are all of the approaches and their character values. So there's an open approach, a percutaneous approach, percutaneous endoscopic, via natural artificial opening endoscopic, natural artificial opening with percutaneous endoscopic assistance, and external. What I want to stress and emphasize with this is it's important to understand what these approaches mean, how they equate in a surgical note. Because I can tell you the hardest thing is a provider is not going to say that they access something through an orifice or through natural endoscopic, natural or artificial opening with endoscopic assistance. They're not going to use that verbiage. So you're going to have to be able to pull it out. All right. The sixth character is the device character. The device must be left in place. Some examples of devices used commonly in procedures: skin grafts, IUDs, pacemakers. The important thing to note here is that the device must be left in place during the or after the procedure. So you can't bill for a device that you use only in the procedure, like a catheter, because you're not actually leaving it in after your operation. The seventh character is the qualifier character, and this is used to identify unique values or information specific to procedures. This varies based on root operation. An example, we talked about the root operation detachment. The qualifier character is going to indicate actually more information about the detachment. It's going to relate to us, was it done on the high, mid, or low part of the bone or extremity. So this will identify unique information about the procedure. Also, a qualifier will identify, we talked about in the very beginning, the root operation excision. The qualifier character for excision, or I'm sorry, not for excision, for biopsy is X. So if you see an X in the qualifier character and it's an excision procedure, you can bet it's usually going to be a biopsy because that is the qualifier that indicates that it's a diagnostic excision. Some other things that qualifiers identify: type of transplant, the second site for a bypass. Those are some additional pieces of information that are identified by qualifier.
So the important thing to remember about qualifiers is that if you feel confident in your root operation selection, and you can rest assured that you've gotten to the right table in PCS, you'll know which qualifiers are available to you in that table. They are the only ones you can choose from to create a valid PCS code will be in that table for you. So really being really confident about your root operation and body part selection are going to be key to making sure you select the appropriate qualifier, because there isn't a list of qualifiers. The qualifier values and definitions vary by body system, they vary by root operation, and sometimes they vary by body part. So the first 4 characters you select in that code are really going to drive what your 7th character options are for your qualifier.
And most procedures will not have an applicable qualifier. The majority of procedures that you deal with, they won't have the actual option for a qualifier. So you don't have to stress about that too much if you are in an inpatient setting, but you do need to understand how to use it and how to find what qualifier.
So we just did flyby ICD-10-CM and PCS, which is clearly doesn't give you all the tools you need to apply this in whatever practice or setting that you work in. So we are offering the AHIMA content to train coders cover to cover, CM, and PCS. CM cover to cover is going to be important for a lot of specialties. Codes for, in your particular specialty or setting, codes which maybe you didn't have to use from certain chapters before, because of the reclassifications and the concept additions, you may find yourself living in more chapters than you do in ICD-9. So specialty-specific education is important, and specialty-specific familiarization with the codes is important, but an overall understanding of the text and overall familiarity with the codes is equally as important. So we're offering ICD-10-CM and PCS coder academies for those of you who code in a facility setting and need to utilize PCS. It's a 3-day training. The full 3 days would be required, because you'll have to apply CM and PCS in your day-to-day coding. So our coder academies they're hands-on, they're interactive, they're utilizing the AHIMA content, the very content that we were provided with when we became AHIMA-approved trainers. We do a lot of workshopping, lots of opportunity to apply the knowledge you've learned, apply it immediately, apply it often over the course of the 3 days. If you are in an outpatient setting and you only need ICD-10-CM, you may only take the first day, and that day still includes workshop with ICD-10-CM only. Once we move into the additional days, we start workshopping ICD-10-CM and PCS, so you're actually coding your diagnoses and your surgical procedures. The training sessions, they're going to be very coder-centric. Lots of workshopping for people who really coding is a part of their day-to-day. Not that your providers and your management staff shouldn't be familiar with ICD-10, but these particular trainings are really going to involve a coder or someone who functions as a coder in their setting, sitting at a desk, learning about coding and applying the codes. They'll be taught by coders for coders. The full training is only 3 days, so it's 3 days out of your life over the next 8 months to really help you be ready to apply anything you need to apply starting October 1st, 2014. So we talked a little bit about the structure. The first day we do CM, cover to cover, and the structure involves reviewing the concept additions at a high level in the beginning, the additions that kind of apply across the board, convention changes that apply across the board. And then we say the chapter-specific changes and additions from when we start learning about the specific chapters. So we start with the big concept change in Chapter 19, kind of like we did today, and then we go back and we move through the book cover to cover. We go through each chapter individually with any applicable guideline and concept changes, and then we spend the time immediately following that workshopping that chapter. So you get to apply it immediately, and then you'll have additional exercises in your workbook where you can go back and mix it up and apply them at random and see how well those concepts stuck. Days 2 and 3 are ICD-10 PCS. And the important thing to remember about ICD-10 PCS is there really isn't a way to train ICD-10 PCS in a specialty-specific way. The root operations could apply to any surgeon at any time, because diagnoses and conditions and types of procedures are no longer incorporated into the ICD-10 PCS code definitions. And because they've reclassified them to not include those types of things, for anyone working in the facility setting, ICD-10 PCS applies to you cover to cover. It applies in its entirety. And those root operations, you will have to familiarize yourself with each of those root operations. So days 2 and 3 are ICD-10 PCS. We talked about one of the 3 sections of ICD-10 PCS today, and while it's the largest, it certainly doesn't, that's not the whole text. So we actually do the whole text cover to cover, even those root operations and sections outside of the medical surgical section. And it's formatted much the same way. We review those conventions and concept changes that we need to know to apply across the board first, And then we talk about chapter and, well, for ICD-10 PCS, root operations specific guidelines as we move through those certain root operations. We learn about a root operation, we workshop, and we apply it immediately after. We learn about a group of root operations, for example, the 9 groups that we talked about today, and then we have a series of exercises that kind of mixes those up. So it really tests your capability to discern the nuances between transfer and transplantation or whatever it might be. So you're given every opportunity to really apply the knowledge. We don't just throw the knowledge at you and then send you out the door. Day 3 involves a lot of workshopping with complex op reports. So you're given the opportunity to code both the surgical procedure and the diagnosis. So you will apply the knowledge you started learning from the beginning of day 1 all through the middle of day 3 to those complex op reports. CEUs are granted, and while this is a HEMA content, AAPC does accept these CEUs. You don't have the agenda. It is the detailed agenda, which essentially just breaks down the timeline, the hour, which hour we review which chapter, is available on our website. Our website information is on the very last slide, so I'll make sure I pause and give you enough time to write down that information. It's also on the bottom of each of our personal slides. And certainly if you have any contact information from us in the past, if you get us an email, we'll be able to direct that to the right person. And info@rtwelter.com is shown down there. So the Coder Academy, that's in a nutshell. Really our goal is to, any way that we can, to feel as confident as you can, to begin applying these codes on October 1st. You'll receive the same content that we received, like I said, not only in regards to the material we're presenting, but in regards to the material you actually get to take with you that day. You'll receive the text, either one or both, depending upon the days of training you need. You'll also receive the AHEMA workbook, either for CM, PCS, or both. The workbooks are such a great tool. Not only do they give you exercises for every single root operation, so you don't have to dig for op notes to use as examples in your own setting. They give you chapter guidelines that apply to each of your answers. They give you rationale. They give you additional notes that you can't even find in your text or anywhere else, just kind of pointers. The rationales are great. The pointers are great. And the fact that they really lay it out with which guidelines apply to which root operation selections, it makes it a lot easier to bring together. Like, as I mentioned before, CEUs are available for each day, and the workshop will be taught by coders for coders. We're offering a March session, a June session, and these are both live sessions. The June session is in Thornton, Colorado. I know we have a lot of attendees listening in from out of state. Our operations manager she would be able to make travel arrangements for you, things like that, if you're interested in attending one of these live sessions. Probably too late to do that for the March one, but for the June one, please inquire with us, and we'd be happy to help you in any way that we can to make it to us. We are also offering, for those who simply can't make the logistics of Thornton, Colorado work, we're offering a virtual Coder Academy. We will do it in the exact same format, so it still will require that your attention is on this material for that either 1 or full 3 days, but you will be able to do it remotely from wherever you're located. The presentation material will be the same. Workshops will be provided in a polling format, so that format has to change a little just due to the nature of the virtual structure. We're offering this in July, and you can find all of the information on our website. So to give you an idea of the cost, this is really affordable. Not even just for the information you're getting, which I truly believe, just to give you an idea, particularly those of you who code ICD-10 PCS, I went in to train the trainer with a HEMA with no inpatient coding knowledge, and I can utilize ICD-10 PCS. So it really, the content is formatted in such a way to help you use the information and to help you use the information in a very real-world way. So to give you an idea about the cost, people who, those of you who only need ICD-10-CM, that would be day one. It is $275 for the 8-hour day. That does not include the cost of your text. You will need the ICD-10 text in the workbook, but that includes the full 8 hours worth of training and your 8 hours worth of CEUs. Those of you who need both inpatient, who need PCS and CM, the full 3-day academy is $800. That's 3 8-hour training sessions, 24 hours worth of CEUs, and then your training materials, your text and your workbook will be additional to that. We are offering registration discounts for groups. So have your clinic send all of your coders. We're offering discounts for 3 or more participants from the same practice, from the same group. So please inquire with us. We really do want to help you. We have a passion for teaching this material, and we want to make sure that you have the tools you need to succeed after October 1st, and have the tools you need to be ready to succeed before October 1st.
All right, so Whitney talked to you about the coding or coder biller training opportunities. We have also developed some physician and very, common practice A to Z implementation training. So we've developed a training program called Chief, and it's essentially 5 steps, a lot of stuff crammed in these 5 steps, but we take you from start to finish through ICD-10. So step 1 is collecting your data. We're looking at your top 25 diagnosis codes or your top 50 if you're orthopedics, and we're taking those codes and that data and we're forward mapping. We're creating forward maps, not just with the gyms, but we're actually, as a coder, taking the codes and giving you all of the possibilities. We're also creating cheat sheets to help providers. Many of us will find with ICD-10 that the super bill is no longer going to be, it's no longer going to be possible. You can't fit all your codes on one page anymore. It's very hard to do that, particularly with those specialties that deal with injuries, because your code could be different for every single encounter. So that is actually part of step 1. The biggest part of step 1 is that we look at 10 of your provider notes, and we audit for current ICD-10 readiness. So we see where you're at with ICD-9, what kind of documentation you are documenting now to see if you're ready for ICD-10. And that audit basically drives a lot of the rest of this information. So step 2 is where we come in and we train your coding and billing staff, any staff that is involved in the revenue cycle process. We come in and we do a very intensive training. We go through the general concept changes and those things very briefly, and then we dig right in and we start actually coding in a workshop format. And we take your notes from the audit in step 1 and we customize the training basically around those notes. So that is step 2. We talked about the Coder Academy. If you are thinking about doing that, I greatly encourage you to do so. That does not replace this step. This step is really separate, and again, we tailor it specific to your specialty and your practice and your needs. Step 3 is where we do very intensive provider training. So as the first piece of that, we come in and we do a specialty-specific group provider training where we basically dive right in and we focus on the documentation changes, the conceptual changes, what your providers need to know as it pertains to their documentation. The second piece of that step is we take the audit from step 1, and we sit down with your provider one-on-one, and we go through their individual documentation findings. So we identify how they're doing with ICD-10 documentation currently and kind of bridge the gap between where they are and where they need to be in that session. Providers have a lot of questions about ICD-10. They're very skeptical. There's been so much hype about it. And, we really give them the information that they need to know in this one-on-one, hands-on setting. Step 4 is where we evaluate your vendor readiness. We query EMRs, we query clearinghouses, we query the payers to find out where they're at with ICD-10, and we let you know as it pertains to your vendors. I can tell you that Medicare is testing for ICD-10, our Medicare carrier. I keep forgetting that we have some out-of-state people. Our Medicare carrier is Novitas, and we will be testing next week, so March 3rd through the 7th. If you are in our region and you have the opportunity to test, I encourage you to do so. But this is the kind of information that we're going to be relaying to you in step 4. Step 5 is basically taking steps 1 and 3 and doing it again. We're tying our loose ends. So we're going back and we're re-auditing 10 notes per provider after we've educated the provider in step 3. So we're taking it full circle, and we look at their notes, we review them, and then we sit down with them one more time and draw it all together and say, here you go, this is what you need in terms of your documentation to be ready for October 1st, 2014. Step 5 is very important because, we really take the approach with this training to come in and make you as ready as possible. We have a lot of clients that are on modified versions of Chief. So if steps 1 through 5 sound like, that doesn't really fit your practice or your needs, we can modify this plan to help you. The most important thing about ICD-10 is preparation. That is really all that it boils down to. If you prepare, you're not going to see the loss in productivity, the loss of payment and delayed reimbursement. You won't see those nearly as much as someone that has not prepared. And I can tell you, every office and every practice is kind of different on their timelines. So, some practices have started already. We started working with them in December because they're larger. Some of the smaller practices, they don't want to give their providers information too soon. So, we start the Chief Training Program later in the year, around May or June. The most important thing to keep in mind is that you are giving your staff and your physicians the proper resources and tools to succeed in ICD-10. And the only way to do that is by training. So we have created many training opportunities for anybody that is interested or that needs training with ICD-10, which is everybody. Everybody is required as of October 1st, 2014 to adopt ICD-10 with the exception of non-HIPAA covered entities. So we're talking about work comp, auto, they're not required. So if you have payers or if you have those payers that you bill to frequently, you have to consider you may be using 2 code sets for the foreseeable future. ICD-10 is going to affect so many things.
I know a couple of questions were rolling in about the slide availability. These slides are not available for printing, with the exception of obviously these last few slides, which have been our personal slides. The majority of this is a HEMA Train the Trainer content, which is not available for redistribution. It's available to us as a HEMA approved trainers. we provided to you this afternoon a snippet of some of the types of training and tools and information that we would provide via the Coder Academy, via another method of ICD-10 training via Chief. This webinar, however, in its entirety, will be available on our website for you to view for free. Again, if you choose, if you had members that were not able to attend today. So the information will be accessible to you, but not in a paper format. CEU certificates will be delivered to you via email, since we didn't have the print function. If for any reason you don't receive a certificate and you were present, please email us. If you have our info@rtwelter.com, that's okay. I've also included my personal email address, and I can get you that certificate directly. If there are any, I know there's been a few questions filtering in. If there's any questions about anything that we've talked about, feel free to use the chat function. We're going to kind of wrap it up, open it up for questions, address anything that you need us to address. Remember, everyone can see your question and they can hear us, so everyone should be kept in the loop if you submit anything you want us to answer. Email is again listed on this last slide, so just make a note of that. That's also where you'll be able to access this the recorded version of this webinar again. We had a couple questions filter in. I'm sure that you've seen the answers if you're viewing the chat box. ICD-10 PCS is not replacing CPT, those codes that are reported in the outpatient setting. Only those inpatient, that inpatient reporting done via ICD-9 Volume 3 codes now. Please use those CMS resources, particularly those of you who are coding ICD-10 PCS. I highly, highly recommend referencing the reference manual. When we do train the trainer, that's one of the prerequisites, really kind of diving into that reference manual and putting some additional information about the root operations in your brain before you come in and apply the root operations and apply the codes. So I strongly recommend reviewing that material. And like I said, PCS is going to be a cover-to-cover thing. We just got a question, is the professional component of a PCS procedure coded in CPT? No. CPT and PCS will very much live in different worlds. CPT will be our outpatient reporting mechanism. PCS will be our inpatient reporting mechanism. If that didn't clear up the question, filter something back in. But no, they live in completely different worlds. And that's, I guess that's the best way I can think to describe it. They're never opposing components of each other. They live in completely separate worlds.
Yeah, so if you're submitting codes for an inpatient procedure, you're not going to have any CPT codes. It's just going to be ICD-10 PCS procedure codes. That's not changing. And, you know, as I said when I was talking about ICD-10 PCS, this is such a substantial change, and there are so many people out there that are kind of a little in limbo because, you know, we don't know how it's going to pan out. We don't know if DRGs are going to be affected. We don't know, you know, a lot of the unknowns that are identified in an inpatient setting because we haven't used the code set yet. Same thing with ICD-10-CM, just in a different perspective. ICD-10-CM, you know, in an outpatient world, we don't get paid based on our diagnoses. It affects our medical necessity, but it doesn't necessarily affect our payment. In an outpatient world, we basically focus our attention mostly on CPT. With ICD-10-CM, I can tell you there's going to be a lot of push for more emphasis on correct coding and identifying the most specific ICD-10 code.
If we don't get any more questions filtering through, I think we're about ready to wrap it up for the afternoon. So I'm just going to give it 30 seconds or so, see if we have any additional questions come through. If anything pops up later, feel free to contact us via email. We want you to feel confident about the ICD-10 coding training decisions you make. Okay, I don't see any more questions. It doesn't look like anyone's in the process of submitting. So that concludes our webinar for today. Visit our website, rtwelter.com, to view the recorded version of this webinar and to access additional information about ICD-10 and ICD-10 training. Thanks for joining us today, and we hope to talk to you soon.